quick question. What is the current price difference between Gleevec and the cheapest generic?
Right. It's nearly a fifth of the cost, approximately.
Imatinib was £100, wasn't it, a tablet?
Yeah. So the NHS price is confidential, but I think it's approximately about a fifth or a quarter of the price of the branded Imatinib. Teva was similar price till about December, and they bumped up the price. So from Teva, NHS England, most of the trusts have switched to the Amarox, which is one-fifth to a quarter.
Right. So, is the medication, could it be affected by any other medication that a patient's on for other causes? It's
the same for all, I would say, tyrosine kinase inhibitors, the tablets we take for other cancers as well. So there's no difference between Gleevec and generic Imatinib, what other drugs affect. For example, omeprazole has an effect, some of the antibiotics have an effect. And if you look at the GIST, Support GIST Cancer UK, a small booklet we have, it gives you a list of drugs which will interfere or interact with Imatinib, sunitinib, regorafenib, or other NIBs as well. That's correct. It's the same for all Imatinibs, all types of Imatinibs, whether generic or Gleevec. In fact, it's kind of a what we call as a class effect. So most of the NIBs have the same kind of interaction with grapefruit juice and those NIBs as well.
Yeah, a naive question. Why don't Novartis bring the price down now it's out of patent?
I can't answer that question, but it has happened before where the patented compound, because of the competition, they dropped with other drugs. It has happened before. I wouldn't be surprised if Novartis does, but I'm not going to say this, but maybe Novartis has moved on and they think Gleevec is in the past and they're looking at new drugs and new cancers and everything. But yes, that's actually a very good point, because it has happened with other branded medicines where the company which originally got the patent dropped the price down to match the generics, and then we went back to the branded compound. Yes. You can dissolve in water, warm water, or orange juice. You can drink it like that. We've done that before with patients who had a nasogastric feeding tube and they could not swallow things. So with various NIBs or this kind of tablet medications, we've done that. It doesn't lose the efficacy from what I can remember.
What about whiskey and brandy?
Slightly different question. So I'm interested in the process that these drugs go through, so when they're patented, because Gleevec or Imatinib wasn't actually purposed for GIST to begin with, was it? It was for leukemia, I think. So if a drug is in patent and is then repurposed for something else, does the original patent still apply, or does it restart, or how does the process work?
Yeah. So as you rightly said, Gleevec started journey as STI 571 from chronic myeloid leukemia.
Through the process of updated marketing authorization, yep. So they reapplied. They reapplied for new indications, but the patent is basically to protect the invention of that drug, and you can add things to it, but the patent will, yeah.
What we have to understand is that to get a molecule from bench to bedside, which is the process which Laura has talked about from the preclinical trials, early trials in human beings, and then get into a randomized study where it does show that it's good enough to be licensed. You're talking of billions. So that's where sometimes I feel that the rare cancers we lose out, because for common cancers like breast cancer, bowel cancer, lung cancer, prostate, they can recoup the money very quickly. Whereas with us, when you got patients with, say, for example, GIST or some other rare cancers, it's difficult to recoup that $1 billion or $2 billion who they have invested in. And so they actually bump up the price to actually, it's happening with some of the newer drugs which we desperately want to get into our, for our GIST patients. We can't because the way the funding or the way the marketing is going on, we are finding it difficult to get them into NHS. It's already happened with one of the drugs, Imatinib, which NICE said no. And the worry we have is that some of the drugs which have got niche use in the GIST world, like Imatinib is the best example, we may not get them in UK because of the cost considerations. That's a major worry for us.
Oh, sorry. Yes, sir. Hello, my name's Tina, and I've got a question based on some recent experiences after being switched from Gleevec to a branded type. I was on Gleevec for 2 years, and I got switched last June. By August, I was extremely poorly. I didn't know it was related. My symptoms were a severe cough, which developed into double pneumonia at the time, I thought. But then it became apparent that it was, my oncologist and a cardiologist have now said that it was a drug-induced pneumonitis, if I've pronounced that right. Yeah. So I was extremely poorly. I was taken to A&E. And at the end of it, my oncologist said, it's due to switching, and you are coming off this branded. I was off it for 5 days, and I'd recovered completely. I've got no doubt in my mind what I went through, that it was the switch that caused me to be so poorly. So my question is, because it's only been switched in the last 10 months, if I'm understanding that correctly, I understand that Cambridge is collecting the data on how people are responding to the effectiveness and the side effects, but are all hospitals doing that? And are they collating that information so that, I don't know, 18 months' time, there's going to be a lot of data to say, actually, this has happened across the country, not just Cambridge. We've had 6 women or 6 men admitted to A&E with lung difficulties as a result of the switch. I just didn't know if it was all hospitals doing their own collation of their findings or whether it's being collated nationally, because I think that would be very interesting.
I've grabbed the microphone before you've answered because this is really a follow-up question. Obviously, the pills contain things other than imatinib, and I wonder whether your side effects, for example, were caused by one of the other components of the tablets, which are not part of the original, it's not the imatinib, but it's the other additives. And another question is, different hospitals or different trusts are obviously using different generics, and do they all have the same occasional side effects, or are the different generics all having the same sort of results? Has anybody looked at this?
No. The simple answer is no. It's a fantastic opportunity for us to actually collate and collect data collectively in the NHS. And again, Marsden. Yeah, I think in the last 17 years I've been using Imatinib or Gleevec, we only had 2 patients with drug-related pneumonitis. It's extremely rare. And the first patient, we had to stop it completely. This is a number of years ago. Patient has been fine. Second patient, I stopped the drug and put the patient on prednisolone, which is a type of steroid. which the pneumonitis responded very well. It's an inflammatory response. It's not infection. It's an inflammatory response to the drug or components of the drug. And while the patient on a tapering dose of steroids, we have gently reintroduced the Gleevec at that time, 100 milligrams twice a week, 3 times a week, then 5 times a week, then build up to 200, then 300. So the patient has been back on Imatinib for nearly about 6 years now on a lower dose of Imatinib. But drug-induced hepatitis, or that one I've shown, and drug-induced pneumonitis, certainly with Imatinib, are extremely rare. But if you had a switch and it happened to you, then the 2 and 2 equals 4. That's a reasonable assumption to make. What we can't answer is whether that is because of the ingredients you were talking about, Judith, or whether it's the drug itself. Other thing what we've learned is that the Imatinib-related drug in pneumonitis usually happens in the first few months. So yours happened in the first few months after switch. Yeah. I mean, that what we call is temporal relationship, the time kinetics seem to indicate that this is probably drug-related pneumonitis. It didn't happen with Gleevec when you've been on there for 2 years. Are you back on Gleevec now? Right, okay. So what's the situation with regards to your disease?
Thank you. The plan was to stay on it for 3 years. This happened at the 2.5-year point.
Right.
I've not taken it since 2.5-year
Right.
point. I've had a recent PET scan, an MRI, and there's no progression,
Right.
which is great. And obviously I'm going to be monitored now very closely.
So you were on the adjuvant Imatinib rather than metastatic disease, meaning you don't have too
I
much
don't
spread.
have a secondary,
Yeah,
no.
that's right, yeah. So adjuvant Imatinib. So I think there the difference is that you need to balance the potential benefits of adjuvant Imatinib, carrying on a bit longer to get to 3 years, and also potential risk of causing pneumonitis again, because that can be potential life-threatening side effects. I think they made the right decision by getting you off the Imatinib. I would have done the same thing. In the metastatic setting, where the tumor already spread and the patient's been on Imatinib for a while and they get the side effects, I try and get them back onto the drug if I can, and if it's safe to do, and try and use every trick in the book kind of thing to get them back onto the drug, knowing that if I don't do that, the disease will progress. So there's 2 different issues here. In the adjuvant setting, you take less risks. Especially if you say, for example, somebody's got a 15, 20 centimeter small bowel cyst and mitotic index is 50. Their risk of relapse is close to 100%. And they get side effects in the first 6 months or 1 year or 2 years. My view about that risk taking would be very different to somebody who's got a gastric cyst, say 7 centimeters, mitosis is 7 or 8, and the risk of relapse is moderate, maybe low, high kind of thing. Then the discussion I have with that patient is very different to the other patient. So you need to make sure that you look at the benefits here and the risks you're taking, and have the dialogue with the patient, the family, and agree what you want to do. That's what I do in my practice. So that patient I talked about, the 16 centimeter small bowel, just 50 mitosis, even though the patient may have had a severe side effects, I would try and get the patient back onto Imatinib if at all possible, because he's got Imatinib sensitive mutation, he's got 100% risk of relapsing. I want the patient to be on the drug for a long time. So there were ways of doing it.
Thank you.
But in your case, I think it's the right decision.
Thank you. So going back to my question, how is the NHS collating such incidences and not just random each individual hospital? Because if I've had it at Oxford and somebody's had it in Cambridge and Glasgow or wherever, if each hospital thinks it's only happened once, but actually it's been 20 in the country in 18 months, then maybe that's more of an issue.
Sure.
So I was just wondering if there's any plans to collate that data.
I mean, ideally, I think what we should be doing is using the yellow card scheme. There's the MHRA's yellow card scheme. We have to fill in the details of what untoward effect is, and then send off the MHRA so that they can monitor. It may not happen in every single, in a busy clinic sometimes. Sometimes we want to do it at the end of the day, but we forgot. And So I know that in my own practice, sometimes I didn't fill in the MHRA, the yellow cards, but it may be an opportunity for us to collaborate, maybe 5, 6 big centers, looking at the Marsden ourselves, Christie, Birmingham, Glasgow, Newcastle.
Can you include Oxford, please?
Oxford, no, nothing against Oxford. I'm from Cambridge, but I'm also Oxford trained.
Thank you very much, thank you.
I love Churchill Hospital, so yeah.
Yeah.
I think it's, the challenge we have is somebody need to coordinate this. Somebody has to have the time to coordinate. Otherwise, it comes from the patient champions. It's fantastic if we can just consider we can as collaborate and as a project. Pardon? Well, it's not that easy. It's not that easy to collaborate on a bigger scale. What we can do is within the NHS, we can actually use what is called a service improvement project, which does not require ethical committee approval because we're not actually looking at intervention. So we can actually use that as a kind of audit or a service improvement. And a lot of research and development departments in the hospitals, they're very nervous about sharing data. So within our hospital, we're happy to have our data in our thing, but Marsden comes along and they want to share our data. It's not that easy. But it could be an opportunity for us to, because this is an issue for us, it's not going to go away in the sense there's going to be more patients coming through. As you rightly said, if we could say, I've seen only 2 pneumonitis in the last 17 years, both of them were on Gleevec, not on generic Imatinib. But in the next, say, 8 months or next, say, by the time we get to 2 years on the generic, we've seen 16 cases of drug-induced pneumonitis. Then we have to ask the question, is it really safe to actually to stay on despite it being cheap? Because this is a life-threatening, serious side effect, though rare. I think you're right. I think we need to go back and talk among ourselves whether we can actually collect the data.
Any other questions? I'll come back to you. So life president, I can't really, yeah.
Cheers. My name's Lee. I got diagnosed with GIST on Tuesday. Relating to the question on ingredients, so there's been some high-profile cases in the last couple of years of generics being taken off the shelves because ingredients were present that shouldn't have been there. So the osmoprazole, the anti-antacid tablets, they've all been taken off the shelves in the last couple of years because, chemicals there that shouldn't have been there. So for the quality assurance testing for this drug, has any generic providers of that drug failed the quality assurance and so the NHS hasn't been able to use them?
No, I don't think so. The MHRA, EMA, and the FDA, they have very similar robust processes to make sure that the drug and the ingredients meet the quality assurance
and EMA
level.
As well. The European Medicines Agency as well.
European Medicines Agency as well, because the drug Amarox is actually manufactured in Europe, though the parent company actually is based in India. And I've seen the data. They actually satisfy all the regulatory requirements. Same thing with Teva. Teva is a very big, huge pharmaceutical company. So I think the concern we have is, like you said, if you switch and you get significant serious side effect, do we believe this is the drug, the generic which is causing it? Is it purely by chance? But in your case, it looks very much like, you've been on the drug for 2 years and suddenly it happens, because this is a rare side effect. And we don't see that 2.5 years down the line. Almost all the drug-induced pneumonitis we have seen happened in the first few months. And same with the drug-induced hepatitis, inflammation of the liver also happened in the first few months. It doesn't happen when you've been on the Imatinib for 7 years or 8 years. So it doesn't happen. Same thing with the bone marrow problems with the Imatinib. Very, very rare, but if they're going to happen, they happen very early, not 10 years down the line. So I think when you have that temporal or time relationship, then you have to say this is probably likely to be linked. Though a blanket statement would be, oh no, it can't be. But in your case, I think it could be.
I think you've already answered my question. I mean, I was going to say surely it can't be just coincidence that Tina had this awful side effect immediately after the switch. There must be something in that generic which has triggered this, or the way the drug is released into the system, or something. There must be something there which is different and potentially dangerous.
Yeah, I agree. Other thing which we haven't put in the equation is the COVID. That's another thing which we had a patient who had COVID pneumonia, which was the differential diagnosis was drug-induced pneumonitis. Luckily, the radiologist who was an expert in COVID pneumonia worked out that actually, it was COVID pneumonia, not drug-induced. We have not. Yeah. Yes. Yeah. Yeah. No, yours actually is very typical drug-induced. You come off the drug, you get better. Whereas COVID pneumonia won't get better if you come off the Imatinib. And yeah, I think we need to go back and, I'm obsessed with collecting data in my practice. I collect every single bit. You cough, we record it. You sneeze, we record it. No, seriously, we do that. We've been doing for about 17, 18 years. So we got data going back to 2004, 2003. So how many patients with just had prostate cancer or bowel cancer or breast cancer? We got the data. How many patients had GIST and CML? We got data. There's a patient who got CML and GIST. Both are treated with the same drug. And we got patients who had non-Hodgkin's lymphoma and GIST. We had patients who had other sarcomas and GIST. So we got data going back to 2003. So we are obsessed with collecting data in Cambridge. Same thing with the drug-related side effects. I know exactly how many patients had drug-induced liver problems and drug-related lung problems. And this patient with the memory problems is the first patient in 17 years who had serious memory problems. He couldn't function. Stopped the drug within 7 to 14 days. His memory got better. And it has to be drug-related. It can't be anything else. And it is generic Imatinib. We've never seen that with Gleevec. Never, ever. And if you look at our last number of meetings we had in the last, 15 years or so, we never had that kind of a reporting from a patient saying that, no, I had serious memory problems when taking the tablets. So I think we need to be very, very vigilant and very careful, not dismiss patients. One of the things is, I know the best, I'm the oncologist, go away, keep taking the tablets. That happens. That does happen from time to time. And GIST cancer care, as your voice, should be able to challenge those kind of assumptions as well, that actually the oncologist knows the best. That's not necessarily true. We're learning. If you came to me in 2003, 2004 with that kind of symptom, I would have said, I don't know, could be. Whereas now I can be confident and say, yeah, it is likely to be the drug-related kind of thing. So how we collate data is a bit of a challenge in the NHS with all the kind of constraints we have. Partly time constraints and partly kind of this, not paranoia, but concerns about data sharing. Identifiable data, for example. But it's not insurmountable in the sense we can overcome these things, but it does need a bit of a head-banging, 5 or 6 of us sitting together. And in fact, not a bad idea to have the medical advisory board, the GIST Cancer Committee was about to come up with some kind of a program in the 5, 6 major hospitals and collect data prospectively or even retrospectively going back to say 2021, and then collect it in the next, say, 12, 18 months and reassure ourselves. And when we meet up in, say, in 2023, this is what the data we have on 500 patients, not just 48 patients, 500 patients. But if that 500 patients, we see 10 or 15 drug-induced pneumonitis, then that would be a serious concern. Our drug-induced hepatitis, for example, we see a lot of, because we had a patient with, who we stopped the Imatinib, generic Imatinib just last week. his ALT, which is the liver enzyme, normally under 50, went up to 550. And he's been on imatinib for about 2-3 months now. And his baseline ALT, the liver enzyme, was normal. And we stopped the drug because we cannot take a risk, because this happened while on the drug. But at the same time, we also cross-checked what other medications the patient is taking which could be potentially damaging to the liver. What is the most common damaging substance to the liver? There you go. So we had alcohol last night, or night before. Alcohol is a hepatotoxic drug. It's a drug. And this patient has been taking a lot of alcohol. So we just said, come off, please, just make sure that you only take in moderation. He's taking 3 or 4 pints, that kind of thing. With another drug which potentially could be damaging to the liver going through the same system, you could actually sometimes be mistaken that it's the imatinib causing the elevated liver enzymes, not the other drug. So we just come off the imatinib temporarily, come off the alcohol, and then recheck the liver enzymes weekly for the next 4 weeks, make sure that liver enzymes settle down, then reintroduce imatinib at a lower dose, gently, 100 milligrams, 200 milligrams. If necessary, give some steroids, but re-educate the patient about how to drink in moderation so that he can actually, we don't say that he can't drink while on imatinib, but in moderation. So that's another thing we have to do that as well. So don't blame the drug straight away, but there might be other reasons. But at the same time, we can't. Yeah. Mm-hmm. Imatinib does not have any what we call off-target effects on the thyroid, but there is an interaction between levothyroxine, the drug you take for your underactive thyroid, and imatinib. In real life, that's not a major, but when you look at the electronic prescribing systems, when you put imatinib in the electronic prescribing system, it automatically comes up as a flag. Do you know this patient is taking levothyroxine or amlodipine or one of the other drugs? There's an interaction, known interaction between the two drugs. I just say benefits outweigh the risk, and I click the button, yes, I want. Yeah. There is an interaction between the two, but it's not a clinically significant or serious interaction between the two. Same thing with some of the blood pressure medications. Same thing with omeprazole. We also have the same problem with omeprazole or any of the what we call as a proton pump inhibitors, all the zoles. So sometimes if there is an interaction, we ask the patient to switch to one of the old-fashioned drugs like ranitidine. That will be probably the much safer compared to omeprazole. But you have to take in the bigger context actually how significant are these interactions. For example, some of the antibiotics like erythromycin, clarithromycin, they interact with imatinib. So again, we are very careful when the GP prescribes some antibiotics. We make sure that it's amoxicillin or comoxiclav, something like that. If they're allergic to penicillin, some other antibiotic rather than clarithromycin. So again, these drug interactions are very important with particularly all the NIBs, imatinib, sunitinib, regorafenib, all of these. But we need to be aware of these things as well.
Just a question for the pharmacy side of it. Understand that a lot of research money's gone into the original product, but once that has finished, there's nothing to stop another company making an exact copy of it. So why is there a difference between the composition of these generic ones and the original? Why aren't they exactly the same in all components?
Sorry. So because the patent that they have is exclusive for the active ingredient, but the pharmaceutical companies are very clever and they are not going to share the whole formula of the actual tablet. What is protected is the active ingredient. So when the patent expires, they say, okay, publish, this is our active ingredient. Now work out how to make a tablet of this. And that's what the other pharmaceutical companies have to do, which is relatively easy. And that's why it only takes between 2 or 3 years, because it's a very small molecule. But they need to put all these additives that, depending on the pharmaceutical companies can differ between generics, and they definitely probably will differ from the brand name drug.
Okay, thank you.
I hope that answers it.
Yeah, that's good. Right, thank you very
Well,
much.
what we're trying to work out is that the parent company, the one which holds the patent, may not share the extra bit of the formulation to the rest of the world. They may just keep it as a secret kind of thing. Correct. Yeah.
Yeah, they're just exactly additives that add either flavor, color, or they bulk because the actual active ingredient can be small. So to actually make it tablets, they need to bulk the tablet, or yet to give the tablet enough consistency or shape. They add different additives, and that's what they don't share. And different pharmaceutical companies have different approaches, and they add different additives.
Surely it can't be that difficult for a chemist to work out exactly what's in a pill of Gleevec.
I think identifying what is used is not necessarily that difficult, but the fact that you have the list of the ingredients, my grandma will share a cooking recipe with me with a very lovely list of ingredients. I'll never get it like her. Never, ever. So it is also down to the manufacturing process and how you give the tablet the actual shape that we see when it goes to market. So yes and no. It can be tricky, I think.
The best example is the small white pill, Amarox one. It's a film-coated tablets. It's a very thin film which coats the ingredients, and the moment you put on the tongue, the patient actually demonstrated it actually dissolves straight away, and it never happened with Gleevec. Gleevec doesn't dissolve in your mouth. It just, it sticks a bit to the tongue, but doesn't dissolve, and you can happily leave it for a few seconds before you get a glass of water, a big glass of water to drink it. This one, you have to be really, really quick. And one thing is the patient who is in his 80s, he just put it between the teeth, gulp it down, or you can actually mix it with water or some orange juice, drink it along with that. That actually minimize because this is a common thing coming through now in the last few months with the new tablet.
One more question here.
You got the slide. Your slide is there. So that's fine. That one, the slide one, the CML slide. The one with the side effects, with the yeah, that's not going. Keep going. Going the other way. So this slide here is the one which I think has got pneumonitis. Does it have pneumonitis? No, it doesn't. No, it doesn't. It's one thing is when the patient is in front of you, you really say, "Oh my God, this is drug induced." But in the last 17 years, we only had 2 patients with drug-related pneumonitis. I wouldn't say drug-induced, drug-related pneumonitis, and only had 2 patients with drug-related hepatitis or inflammation of the liver. And we only had 1 patient with what the nephrologist, the kidney specialist, described as a imatinib-related kidney failure. We've never seen it. In the sense, we know that patients on long-term imatinib, the kidney function slows down. So we measured the kidney function at baseline, say in 2005, and then 2022 you measure it. It actually, there's a drop in the kidney function. Some of it could be age-related. As we get older, the kidney function slows down a bit. But we do know that from a CML patients that there's a clear exposure-related decline in the kidney function over a period of time. But we have not seen in our real life what we call as a kidney failure, where the kidney stopped working. But I have a patient who's on dialysis at the moment, but she's been on imatinib for 2 years for her GIST. The nephrologist who did the kidney biopsy and everything, they categorically said this is drug-induced renal failure. we have some difficulty in believing that, but at the same time, we can't reverse it because this is irreversible renal failure, and the presumption is related to imatinib, but we only seen 1 in 17 years.
When you say we, just to go back to Tina's point, just to clarify, is the we a national database of incidence or your...
Right, okay, that we could be royal we, but we're not royal, so when we say we, I think we share data anonymously, in the sense, if you look at, say, 5 or 6 of us with big practices in the GIST world, we check what's happening and everything. So we have that kind of information within UK, but it's never been kind of published, in the sense you can't get a reference to it. So in my practice, I can say this is what I have. So in the last 17 years, this is what I've seen. I've never seen neutropenic sepsis with imatinib, never, ever. I've seen 1 neutropenic sepsis with sunitinib in the last 12 years, sunitinib around. So, yeah, it is, it's me, yeah. There might be, yes, exactly,
Yeah.
Yeah.
We're going to take that up. That's definitely.
Yeah, I think it's
a point
worthwhile.
that
I
needs
think
taking
it's
further,
very good,
yeah.
a good point. Tina's such a point, actually, that to get this into more of a national perspective and actually collect data at a bigger level.
The conclusions can be more accurate.
It will be more accurate because you've got a bigger data set rather than the 40 patients, 50 patients. You've got 500 or 1,000 patients. And if you proven in about a year's time that in the 1,000 patients, there are only 2 or 3 pneumonitis, which would be the same what we'd expect with the Gleevec, then we'll be reassured that actually it was. In your case, we're not going to doubt it. I think the time, temporal profile of the event, it fits in with what we would say with the drug-induced pneumonitis. If this happened, say, you're on Gleevec and then it happened on year 3, then we would have said something completely unrelated. Yeah. And also, these side effects are not related to the plasma levels. That's another thing you need to remember, that when you check plasma levels in patients like you, on the day when you had the side effect, they're not linked to high plasma. This is what we call as some kind of idiosyncratic, something which we don't know. It happens as inflammation, not as a pharmacological toxic side effect. Same thing with the drug-induced hepatitis. I checked the levels on that guy. His plasma levels are actually satisfactory within that 1 milligram range. They're not like 10 or 15. Whereas some of the other side effects we see with the other drugs, they're related to high exposure of the drug. There's too much drug in the body. So this is more like what we call as an
inflammatory process.
Inflammatory response.
So it could be some of the additives and the tablets that have reacted badly in your body. It could be that, as we mentioned earlier, in these generic versions, the coating is actually not that strong, like it dissolves within your mouth quite easily. So maybe that had some sort of reaction in terms of like the fact it is prepared, the tablet, and then how it gets digested and metabolized within the body, that caused like that sort of inflammatory process within the body. The truth is there is a lot of like questions that we can't answer, unfortunately, but like we know how to play it safe, and like the right decision is like we think is the drug, we just take you off the drug.
Right, I'm going to bring this stage to a close, and Ramesh, is at which hotel, which room are you in? So if anybody needs...
I'm not staying on site. I think if you have any questions, or if you want...
You're going to stay around, aren't you?
I'm going to hang around.
Yeah. See why I call him Yoda, can't you? Anyway, so Laura, Ramesh, thank you very much.